I represent Fortis Groups of Hospital. I am the head for vascular surgery in Delhi NCR, all the hospitals. I have to credit some of my teachers. Top three are from India who taught me general surgery. Then there's Mr. Kyomin Kang who taught me vascular surgery in Singapore. And that young man with the hat you see also fought the war that Harinder's father fought. It was in the Pakistan sector. He was shot in the chest. And as he was being captured, he used his knife and escaped from three of his enemies, swam across the Ichogil Canal and rejoined his unit. And I lost him 6 years back. Stem cell therapy will come in extreme revascularization. What does it mean? It means it is below the ankle. It means the arch is involved. It means there is limb-threatening ischemia. Else it is, we don't call it extreme. We have three options. We do plantar loop angioplasty, which is quite a routine procedure nowadays with good results. Then we also do deep venous arterization, and then we have stem cells. So how do we go about it? I want you to have a good look at this slide. You see, each time you do a CT angiogram or a Doppler, you forget below the ankle. You will not read there. And if you look at the data, below the ankle and arch is 75% contributor to critical limb ischemia. So we are all glory of SFA and tibial, and we forget about the arch. And the odds ratio of losing a limb at there is 13%, which is very high compared to SFA and tibial disease. I will repeat. It is the arch and below the ankle disease that will usually cause limb loss, and usually patient will end up with amputation because we think ab kuch nahi ho sakta, we can do nothing about it. And this is how we define it. Above the ankle I call it transmission failure, blood is not being transmitted. Below the ankle we call it distribution failure. We don't have distribution, and distribution is the key to survival. If we have a transmission but the bulb is fused, you won't have light in your house. Outflow is the key in below the ankle ward. You don't make that arch, your patency rates are not going to be as good as they could be. It is validated in many series. My hospital uses the Rutherford runoff score. You should read it up and put it in your chart and score it to see how good your patency rate is going to be after the revascularization. You will be very surprised. Case 1. 2006 he gets a right fan pop. 2021 he gets a CABG. 2021 again he has an endo fem pop intervention. 2021 again February he gets a redo fem pop. Now this is extreme. Why did everything fail? Because it was below the ankle disease. This was my first case of the stem cells that I was talking about, and finally we could save his leg and the rest pain was taken care of. Case 2. Now this person has got a calcified arteries from right his iliac up to the ankle, tubular, there is no lumen in it. No case of revascularization, CKD, heart failure. I did the stem cells on 13th December, and by 7 days we can see some kind of recovery happening. He died 2 years after my procedure, but he died with the heel. Case number 3, young man, diabetic, the left one I have done a popliteal angioplasty, he comes with an ulcer on the right leg. Please look at the toes. When 14th December, I put the stem cells on 29th of December, and by January his toes have improved and his foot is coming out. Now all is not hunky-dory, you do have some allergic reactions where you put in the stem cells. And in this case, you can definitely document an increasing toe pressures after the procedure. So if you select them well, you do have a proper way out. If you look at the last 18 months, I have done about 65 pedal plantar loop angioplasties, 7 deep venous arterization, and 17 of regenerative stem cell cases. So what would be a good procedure? They always say, leave nothing behind. There should be no stent and there should be no dissection. Overview. Now this is an off the label. You don't have to make it like your autologous stem cells where you take it from the hip and then we centrifuge it. It comes predetermined. Why does it work better? Because they are specific concentrate for the mesenchymal stem cells at a specific dose, so they work better. It has 3 ways. Angiogenesis will take some time, immunomodulation that is very accurate, and tissue regeneration that also takes time. Now, this is the important slide. So, you have a below ankle and below at the arch disease. You have to revascularize. If I want to do a pedal plantar loop angioplasty, my success rate is 80%. I cannot do complete pedal plantar loop angioplasty in all the patients that I take. Of those that I succeed, 80% will have a primary patency rate at 1 year. So if you have 100 cases coming to me, only 64 will be having the leg at 1 year if I do pedal plantar loop angioplasty or a deep venous arterization. If we go to stem cells, my technical success rate is 100%. And the limb salvage rate or improvement rate is 80%. So your overall success does improve if you are using stem cells. But I call this indirect non-anatomical revascularization. That would be deep venous arterization. This is physiological revascularization. So from the gangrene to revascularization, if you don't predict 2 months of time, don't do it. It is different from autologous stem cells because it is more specific and more concentrated. You get more stem cells for this particular purpose. It does not have an absolute contraindication. Now, anything that does not have an absolute contraindication has a chance of being exploited and misused, like IVC filters. It is very easy to administer. Everybody can inject into the skin and talk to the muscles, right? Very few people can do a loop plasty. So there is a big chance of it being misused, which is not very right. It is not an alternative to direct revascularization, which is pedal plantar loop angioplasty and deep venous arterization, but it is one of the options we have in a no-option situation and to save a limb. I will repeat, independence